Welcome, everyone, to today's ReCAST office hour entitled Community Defined Evidence, Joining the Movement. I'd like to go ahead and get started with today's session, and I'll go ahead and do the disclaimer. So the views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. As most of you all are aware, SAMHSA's initiatives under Project Aware and Healthy Transitions. We are working today, and most of you are the ReCAST initiative as part of Project Aware and also as part of the overall initiative. We work to make schools safer, increase access to mental health services, and promote resilience and equity in communities. I believe Tamu is the only presenter who is actually presenting today, so I will go ahead and let Tamu introduce herself. And welcome, everyone, and welcome, Tamu.
Thank you so much. I'm Tamu Nolfo. I'm based in Sacramento, California. I have worked for probably about 25 years, primarily in the field of substance abuse prevention, and have worked at least the last, I would say, 10 to 15 years in the field of cultural and linguistic competence and health equity. And so I'm really excited to be with you all here today. Here are objectives: to support ReCAST grantees in their understanding and vision of elevating community-defined evidence, identify the unique evaluation considerations with this approach, foresee and mitigate potential pitfalls, and learn from existing models and resources. So at this time, if I could put you on the spot and just ask what piqued your interest in joining today's office hour, and if you want to unmute your phone and speak, that would be great. Maybe I can just call on you. Kenyatta, would you want to go first?
Sure, I can say a little bit about our area. We just, the community is fielding different methods to work with in ReCAST, and some of them are not necessarily evidence-based practices, but seem to be practices that have worked in other communities. For example, we've been in conversation with some of the colleagues from the Chicago ReCAST on some of the work that they're doing on restorative justice. And we're not sure that restorative justice would be appropriate for Flint, but we're definitely just, communicating, and also at another meeting that we had in Flint where different ReCAST grantees attended, other people talked about things that they were doing in their communities that were not considered evidence-based, but were, evidence for their communities. Right. And so that's what piqued my interest in attending today.
And what's your role in your effort?
Well, right now I am one of 6 steering committees in the Flint area, and I also work for the state of Michigan as an analyst. Yeah.
Okay, great. And let's see, I also saw Gilbert Gonzalez.
I run the mental health department here in Bexar County.
Okay.
County-based mental health department in the state. The primary focus, or one of the things that I'm very interested in, of course, is increasing access to mental health, and therefore the measurement of that variable and any best practice regarding or surrounding.
Okay, great. Okay, so our agenda to understand what is community-defined evidence, this thing that we're going to talk about, will highlight some examples from the California Reducing Disparities Project, which is a project that is being managed through the Office of Health Equity in the California Department of Public Health, where I also work. And we have some key questions and considerations for dialogue. So once again, this is an interactive session that we have here today. And then I'm hoping that Rochelle will be able to make it on to our call so that she can talk about the National Network to Eliminate Disparities in Behavioral Health, and we'll do some next steps and additional resources. So what is this thing that we're here to talk about today? In a nutshell, a set of bottom-up practices that communities have used and determined to yield positive results by community census over time. Now you can stop and ask questions at any point if any of this, like what is that? That it's derived from a community's ideas of illness and healing or positive attributes of cultural or traditional practices. It includes worldview and historical and social context of a given population or community. And it may or may not have been measured empirically, but it's reached a level of acceptance within the community. So the central goal is to develop an evidence base that works for and matters to the communities most impacted by the conditions, policies, practices, and programs that drive physical and mental health outcomes. And we believe that as this community-defined evidence becomes more widely accepted, that resources are anticipated to follow suit, to be able to scope it out and to better support these practices. And here are some slides, some highlights from the National Network to Eliminate Disparities in Behavioral Health, which, as I said, Rochelle is going to talk some more about, give you a little bit of background. The NITT Learning Cluster consists of a group of community-based mental health and substance abuse providers serving primarily Latino communities, Latino consumers, and university-based researchers. And they started publishing on what they were doing and what they were finding back in 2009. So they developed a framework for community-defined evidence that enhances traditional and non-traditional methodologies for measuring the effectiveness of practices and programs for Latinos. So that's where the terminology and the concept kind of got its start. And as I said, I'm going to hold off and let Rochelle kind of fill in more of the blanks around that. But just to give this historical piece that this is where it's emanating from. So when we're looking at community-defined, evidence-based programs and practices, it isn't just about the outcome. It's much more than just the outcome. And so these are the criteria that we're really looking at to say, is this, essentially, does it meet with our standards of being a community-defined evidence program or practice? And so these are the criteria. Capacity building. Is it essentially allowing the folks who are doing this work to be able to do their work better, to be able to serve more people, to do it, be able to do it more efficiently? So is it allowing these folks to be able to do the work without necessarily calling on outsiders to come in and assist with it? Sometimes initially you need outsiders to come in and assist in the areas that you're just not familiar with or you're not strong in. So you may need, for example, researchers or evaluators or whatnot to come in. You may need trainers to come in. You may need grant writers to come in. But the idea is that over time that the capacity is built from within, and so there's less and less reliance on outside folks. And also when I'm talking about the capacity being built on the inside, it isn't just programmatic staff, but it's also the folks in the community who are the volunteers, who are the residents, who are really the heart and soul around why it is that we're doing this work and that are going to sustain it in the long term, really regardless of whether or not there's grant funding to do it. So that's one of the criteria. The other one is raising public awareness. So, it's one thing to just do a practice in isolation or do a program in isolation, but is it lifting up the public's awareness about why that practice or that program is necessary, why that policy is necessary? Community outreach. So it isn't staying inside of a bubble, but it's actually got these tentacles out into the community. Increasing service accessibility. Once again, that it isn't just about serving a limited number of folks, but it's making sure that people understand what kind of service is available to them and that that service is accessible, that you're breaking down the barriers for people to actually be able to utilize that service. That there are innovative engagement practices, so not just relying on the kinds of practices that may be done in more traditional programs, but that there are ways in which you're thinking through why have these folks not been engaged before and how can we engage them? And maybe that's using technology, or maybe that's using cross-age peer mentors, or there could be a number of different ways in which you're thinking about engaging folks, but it really needs to be innovative. It really needs to be something, let's say, that has been done kind of as standard practice, but hasn't necessarily reached all of the segments that it is that you're trying to reach. And then localization of services and practices. So that's one of the things, is that you're really looking into what are the needs of a particular locale and serving those needs, or looking into the needs of a particular population and serving those needs. Like, why haven't the needs of these people in this place been met before, and answering that question, going after that question. And then appropriate interventions and treatments. Obviously, whatever is done needs to be a good match between what the problem is and what the needs are. So that's one of the reasons why we do, in fact, evaluate the programs and the practices and the policies to ensure that they're appropriate. And the way that we evaluate them is not necessarily the standard way that we evaluate. And so we're going to get into that a little bit more. But when we look at that word appropriate, that's really laden with getting the outcomes that are desired, making sure that what is being done is culturally and linguistically appropriate, that it resonates with people, they feel comfortable with it, they would recommend it to other people that they love and care about. So all of those kinds of questions. And this particular slide actually comes from Dr. Sergio Aguilar-Gaxiola, who's the director for the Center for Reducing Health Disparities at the University of California, Davis School of Medicine, and he also sits on the California Office of Health Equity Advisory Committee. A few examples from the California Reducing Disparities Project. The next slide. So this is a key statewide policy initiative to improve access to care, quality of care, and positive mental health outcomes for racial, ethnic, and cultural communities. And so in California, we actually put on the ballot a ballot initiative that would tax our millionaires. So anyone who's making at least $1 million a year is taxed, and 1% of that money goes to provide mental health services. So that was the Mental Health Services Act. And some of those funds, California Reducing Disparities Project, and some of the guiding principles behind this project are to do business differently. So that involves attentive listening and genuine consideration of community input in order to be responsive to community needs. It's also about building community capacity, which I spoke some about already. It's about investing in creating community structures and supporting community-based organizations in order to sustain efforts to reduce mental health disparities beyond just the funding period. So California Reducing Disparities Project, or CRDP, has a 4-year funding cycle for the grantees. But it's really looking at how can the community capacity be built up so that regardless of what the funding situation looks like in the future, that the community is going to be stronger and able to continue this work forward. Fairness. The program is designed to reduce disparities, so it must be certain to not perpetuate disparities. That contracts should be awarded based on merit and only after all interested parties have been invited to apply and, if needed, provided with tools and services to support their application. So one of the things that we're looking at, and this kind of bleeds into the next one, of system change, is that if the effort to reduce disparities is to be sustained, then we really need to look at the bigger picture. And part of that is not just like awarding contracts to the same entities that have always been in a position to contract with the state, that they have the internal capacity essentially to manage that RFP process and all of the reporting that goes along with it, which is incredibly cumbersome, especially for a state the size of California. So in looking at if we're going to actually have systems change and build in fairness and community capacity and doing business differently, then that means that we have to look at how can we bring in some of the folks who have not been in a position to contract with the state before, and to kind of meet them where they are and to provide the kinds of tools and support for them to be able to play in this game. But I wanted to include this because I know that all of you are doing your logic models, and so when we're looking at CRDP, and phase 2, by the way, is essentially granting out the funds for the projects, and the projects are focused on 5 underrepresented community populations in California, as identified by the legislature. And so those communities are African Americans, Asian Pacific Islanders, Native Americans, Latinos, and the LGBTQ community. And so the funding that is going out through this phase 2 is in support of mental health services that are community defined for those specific communities. Phase 1 was actually those communities coming together and writing a strategic plan that guided this effort. And so we can talk some more about that if you'd like during this hour as well. But essentially, when we talk about doing business differently and what it takes to have community-defined evidence, the process can be much longer because you're really taking the time to get the necessary input, which isn't always a strength of government. I mean, sometimes government just kind of plows forward with the way that it's always done business. And so this is a different way of kind of stopping, backing up, and saying, wait a second, if we're really serious about this, then we just need to go about this in a different way. So the recommendations that came out in that long strategic planning process with all 5 of those population groups represented is essentially what guided phase 2. So what you can see that we have are the inputs on the left side. I mentioned the CRDP strategic plan being one of them, but there's also lots of technical assistance, administrative staff, and support. Obviously the funding that's coming from the Mental Health Services Act and the RFP incentives. And then and by the way, I should mention that the RFP incentives are pretty large for this project, that there's $60 million in funding for this project. And then for the activities that we have pilot sites, but we also have population-specific technical assistance providers. So for each one of those 5 populations that I mentioned, there's also a technical assistance provider that has expertise in that population who is there to support the grantee, to make sure that the grantee is successful. And then we also have statewide and local education outreach and awareness that's coming online now. It hasn't been fully implemented at this point. And then in terms of what else we're looking at for output, so as we're going into the evaluation kind of arena, so what we're looking at in terms of outputs and outcomes, the validation of promising programs and practices, the implementation of strategic plan strategies, the collaboration between community and government, which is pretty key, and advocacy. And so for the outcomes, that you would actually be able to validate these programs and practices, that you would improve the relationship between community and government and that community capacity that I've mentioned quite a bit. And I've also said that one of the ideas is that we would be able to increase funding for these validated community-defined evidence programs and practices, or CDEPs, that once they have gone through this process and have more of the evaluation behind them, that they're more competitive to be able to receive additional funds, and that potentially additional funding sources could open up so that there may be reimbursements through Medi-Cal or different kinds of sources that previously were not open to them. That there would be increases in culturally and linguistically competent mental health services, and policy and system change, ultimately reducing mental health disparities. So you can see some of the external factors down at the bottom. We have our county mental health departments, local decision makers, state agencies, and state legislature. Of that $60 million that I mentioned, about 60% of the funds are going to the pilot projects, but a quarter of the funds are going to evaluation. And I really want to emphasize that because that's a lot of money going to evaluation, but that's really important when you're looking at the community-defined evidence, that you need to be able to build up that evaluation base. About 10% of the funding is going to technical assistance and training, and about 5% to infrastructure and administration. So these are really just some snapshots of some of the programs that are being funded through CRDP. And so just to give a little bit of a cursory idea of the kinds of projects that are being funded, there's one serving African American foster and adjudicated youth at risk for homelessness. And so their program is Tribe, Turning Resilience into Brilliance for Eternity, which has a central focus on brain-based trauma therapy that involves reframing experiences to build positive self-concepts. The Muslim American Society is funded to serve South Asian Muslims and Middle Eastern Muslims residing in the Sacramento area with culturally and linguistically competent and religiously sensitive mental health services that address unmet needs of individuals and families. SHIFA, which is Health in Arabic, aims to identify and treat people at risk for and are already suffering from symptoms signaling the onset of severe mental health illness, and SHIFA has been delivered by peer counselors and interns. HUMANIDAD, which is therapy and education services, serving children, adults, couples, and families in Sonoma County, which is in Northern California, kind of near San Francisco. By providing counseling classes, educational workshops about psychological issues and therapy services, and they utilize a group counseling modality called convivencia, an open and inviting coming together to share personal and collective experiences with mutual understanding and respect, knowing that everyone plays an important role in the community. And there's one more slide that I have on here highlighting is the Gay and Lesbian Center of Bakersfield, which reduces isolation through support and empowerment. They call it RISE, their RISE program, providing structured, facilitated group sessions customized for each distinct population identified as having the highest need for prevention and early intervention and reducing the incidence of mental illness. And some of the other kinds of, so a lot of these are like group-based therapies. Some of the other ones that I have been aware of are like in the Native American communities here, that they're looking at things like drumming circles and bead making and some of the more like traditional hands-on arts and ceremonial practices that there is a relationship between folks engaging in these practices and improved mental health, but putting the evaluation component to be able to make that link. So once again, as I said, that they can go after the kinds of funding that would allow them to do that, to be able to get funding, whether it's from county mental health or reimbursements, to be able to, like I said, fund those kinds of practices that they have been doing for many, many, many years, but have not necessarily been seen as, obviously, as a traditional kind of mental health approach where you sit down with a therapist or whatnot. So there are those kinds of practices that are being evaluated within our Native American communities. One of the other practices I didn't put in here, or programs that I didn't put in here that I'm really familiar with, is one that my mother started many years ago called the Birthing Project, actually here in Sacramento, when she was working for the Department of Health, the State Department of Health, and was really concerned with the African American infant mortality rate. and just recognizing that the way that the state was going about addressing the issue, which it really wasn't. I mean, it was really more just, when the babies were born, putting them into the NICU and spending exorbitant amounts of money to try to save their lives. But from a preventative perspective, that there wasn't a whole lot that was being done. And so this birthing project model that she created was based on pairing up women who were high risk and with another woman in the community who could essentially serve like a big sister to them and take them in under their wing and make sure that they got to their doctor's appointments, or that they got signed up for services if they needed housing, or drug treatment services, to make sure that there was a baby shower that was provided for them. And so that's a model that for sure grew out of the community, that there wasn't like this research base behind it, but then wound up spreading across the country and is now in 9 countries across the African diaspora, with many tens of thousands of babies that have been born into it, and evaluations that kind of came after the fact to look at its effectiveness. But that's quite often what we see with this community-defined evidence, is that you have people who have that lived experience. She was a woman who was 19 years old, living in a bus station with, a baby, with 2 babies actually, and, going through that experience of, what is it like to essentially be at the end of your rope as a young black woman, and what do you need? And so that's why many of these practices come out of folks who have walked down that road and know what's needed. And then, as I said, the evaluation component kind of catches up with them after the fact. And so this is a slide that I actually borrowed from Dr. Cheryl Grills, who is the statewide evaluator for the California Reducing Disparities Project. She's at Loyola Marymount University and just an incredible evaluator. And so she has this way of conceptualizing what it is that we're talking about here with this community-defined evidence as a 3-dimensional model that cannot be separated from context. So I don't know if you've had a chance to look at this slide when these slides were sent out, but essentially you have on the one side the visible elements, and on the other side the invisible elements. And so the visible elements are objective, explicit, they're manifestations of culture. So they're basically just how things show up in the culture. But they're things like, what is the activity? Who are the people that are involved? What do they do? Where does it take place? So there are these really objective kind of elements. But you really can't have this model without understanding and asking the questions about the invisible elements, which are more subjective and implicit and expressions of the culture. So they're the way in which the culture is wanting to put things out to reflect itself, as opposed to just how they're coming out. And so we have a conceptualization of the problem. Different people, based on their historical experiences and their social experiences, are going to have a different conceptualization of the problem. We see that so clearly today with so much that's going on around police violence and immigration issues and all nature of things. So you have different people who are looking at what could be seen as the same problem, but imagining it very differently, especially the perceived causes and influences and the expectations for consequences of intervention. That some people are really looking at consequences should be punitive, and others are, no, they should be restorative. And so these are the elements of this community-defined evidence that we really have to make sure we have all of these pieces that we're considering, that we're not kind of leaving them up to our assumptions, but that we're being as explicit as possible in how it is that we're talking these things through. And this comes from the Annie E. Casey Foundation, which says, evaluations of complex major initiatives are not experiments, but part of the community change process. So this isn't just, let's do research for the sake of doing research, but this is actually the community change process, and we need to be able to document it. So we need to have a strong focus on the process of community change. How is it getting from one point to another point? Not this sort of black box of, oh, it just happened, but no, we really need to be able to understand how it happened. That we need to measure ongoing progress toward achieving outcomes and results in order to help a community guide its change process and hold itself accountable. That we need to understand, document, and explain the multiple theories of change at work over time. You know, quite often we're told, like, well, what's your theory of change? Well, there may be many different theories of change. They may be intersecting. They may be overlapping. They may be at odds with one another. And so are we being as explicit as possible about what those various theories of change are and how they're working over time? And then we need to prioritize real-time learning and the community's capacity to understand and use data from evaluation. So it isn't obviously just a summative evaluation at the end where, you know, you passed or you didn't pass. Like, that's not what we're talking about doing in community-defined evidence, that it really needs to be formative. It really needs to help the community understand what's working, what isn't working, how to grow in real time. So I have some questions and considerations for dialogue for you. Next slide for you. So once again, if you want to unmute your phones, that this is where I really want to hear from you. Why is this approach appealing for your community? And what would you like to achieve through the process? What needs to change, if anything, for your local community-defined evidence to be promoted, supported, and successful? I'm going to move on to the next slide because I also want to throw a few more questions into the mix, which is avoiding the pitfalls. So these are just some of the ones that I've been able to see over time that maybe folks didn't think so much about or that have come back to bite them. Which is under-resourcing and or under-emphasizing evaluation. So I mentioned to you with the CRDP, 25% of that $60 million is going to evaluation, and that's very, very intentional because the idea is that folks are doing these practices. They have been doing these practices for quite some time, but they don't necessarily have that stamp of approval to be able to demonstrate the effectiveness. And so it's really important to be able to put the resources into the evaluation to give that validation to the practices and potentially to modify the practices as well. I mean, it is possible that there are practices that are being done that the community has a lot of confidence in, but really when it comes down to it and they're evaluated, the outcomes are not there the way that they had anticipated, or there may be something else at play with those outcomes. So that's important and valuable information. To focus exclusively on traditional evaluation. So, you know, the way in which evaluation has been done quite often has felt like it's been something that's been done to us, not for us. And so that's what I mean about focusing on traditional evaluation, that there hasn't always been a partnership involved in the evaluation and a critical lens in the evaluation. I think it's Dr. Cheryl Grills who talks about emancipatory evaluation, that it's about the people that are involved in the process. It's a way of taking ownership of the process where, yes, you are going to have your traditional evaluation that you're going to have in your peer-reviewed journals and all of that, because that is what speaks to funders in this country, but you're also going to have an emphasis as well on this aspect of doing evaluation that is more inclusive, that is more critical, that really looks at, are there ways that we can move through this process together, that is more capacity building in nature, that is more formative in nature, like who needs to be here and what is it that we need to learn together. Overgeneralizing the community and community-based evidence, that obviously there are multiple communities, even, for example, within those 5 population groups that I mentioned. And so sometimes we kind of use this shorthand around community, when in reality, when we dig down, there are many, many, many communities with many, many, many different needs and perspectives, and what one community or what one segment of the community may have confidence in or may work for them may not be the same for another segment of the community.
I have a, excuse me, yeah, this is Mike Lozito. I have a question on this. So you were saying under those, the awards on there that 25% was being used for evaluation on those processes. So how does that happen? Because a lot of times, you know, in most of the grants we have to deal with, it's usually, you know, maybe 10% at the most for evaluation. So how were they able to, you know, just
made the case, you know, I mean, in terms of talking about this, like the needs of community-defined evidence, to just be able to make that case that these are practices that are at play that usually are in communities that have been under-resourced for many years, you know, if not forever. And so because of that, they have not had the evaluation dollars to be able to put into evaluating their programs and practices the way that other communities have. And so there's essentially this point of needing to overcompensate around evaluation as a result of that. And because, you know, quite honestly, I think that funders and policymakers don't want to put their money into something that isn't working. And so if you're going to let them know, look, we're going to essentially pilot this, and we're going to put a lot of evaluation into it so that we do know what's working, and then that way moving forward, you'll have the confidence of where your dollars are going and where to put them. So timelines that do not accommodate community government process. I mentioned this early on too. I mean, if you were to look at even CRDP, which has gotten many accolades and lots of national attention for what it is that we're doing here in California, our timeline is way off based on what it was originally conceived to be, because you have to put the time into that trust building that has to happen between government and community, the many layers of bureaucratic process that has to happen in government, which I just was not aware of how many layers there were until I started working in government, that you have to be able to allow for time that you wouldn't necessarily. So for example, when the RFP was being put out for the California Reducing Disparities Project, rather than just issuing an RFP, they issued it first to say, this is what we're thinking about. Why don't you give us input on it? And then they had a period of time where they went around throughout the state to let people know what this RFP was about, to solicit input, all kinds of groups, many, many, many groups. I don't remember how many comments there were at this point, but like hundreds of comments came in on the RFP process. So then the folks in the government had to sift through all those comments, all of that feedback, and actually make changes to the RFP. So for example, one of the comments, I shouldn't say it was one comment, it was many comments that came back from the Native American community saying counties should not be able to apply and be the lead agency on the Native American grants. And so that was one of the ways in which the CRTP changed, that only tribes and Native American organizations could go after those grants and be the lead on them. But that wouldn't have happened if they hadn't gone through that process of putting out the RFP first and saying, what do you think about this? So once again, you need to have this a longer process than you would normally think of, and this last point of overpromising when the institution is not yet ready to do business differently. So what if, you know, we had put out the RFP process and said, hey, give us feedback on it, and then we didn't respond to any of the feedback because we weren't really able or willing or flexible enough to be able to do that. So those are the kinds of pitfalls that you have to think about. You have to know where you stand before you really get yourself into this. And Rochelle, I think I'm handing it over to you now. Next slide, please.
Great. Thank you, Tamu. So
Sure.
Hi, everyone. And my apologies for not being able to join earlier in time to even before the kind of term of community-defined evidence came about. And wanted to share with you information about the National Network to Eliminate Disparities in Behavioral Health. And so this is a national network that was spearheaded under the leadership of Dr. Lark Wong from SAMHSA, who envisioned creating a network through a private-public partnership to help identify best practices or kind of gems in communities that are doing work around addressing behavioral health disparities. And so the NED is how we reference it, and it was formed in 2007 and has grown tremendously to be a free network that anyone can join, and we have over 3,000 members at this point. Okay, and so up on this slide, you'll see the vision and the mission of the NED, which was formed really by a group of advisors who were tasked with helping us create this entity. And so we brought together leaders from the field doing work in behavioral health disparities to help us form the vision and the mission, as well as a structure that really was based on a network model where there wasn't really a hierarchy. It's more of a hub that helps to disseminate information about work in this field to communities. So this slide has kind of what our main focus areas or objectives are of the NED. So really it's to use, to link communities together to help identify pockets of excellence. We know that there's a lot of great work going on in communities, and we wanted to be able to share that with others. And we're looking at also helping to build capacity of our communities that are doing work. And so one of the ways that we did that, and I think this was in one of the original slides in the beginning, was we created these learning clusters. And so one of them that was developed in 2009 was actually called Community Defined Evidence Project. And this was a joint effort between the NED, the National Latino Behavioral Health Association, with support from the University of South Florida, to identify what are some of those practices that are being used in the Latino community to help serve Latino communities, consumers, but that maybe hadn't risen to the top of being a program that had like randomized controlled samples and had a ton of evidence such that they might be in a national database like the National Registry for Effective Programs and Practices, or NREP, and SAMHSA. And so this was effort that was done by the NED to start identifying some of those community practices that folks knew worked but didn't necessarily have the evidence behind it to make it an evidence-based program. And so on the NED's website, we do have the report that was put out from the work of that learning cluster in 2009. And then that's actually what led to the California Reducing Disparities Project through the leadership of Rachel Guerrero, who was one of our advisors on the NED at the time. And so what I want to highlight for you today is on the next slide is NED Share. And this is created as a collaborative space to share, to learn, to connect with community members on innovative interventions and resources that you could be doing or are doing with diverse communities. So people can submit interventions to us that they have going on in their communities, or you can go into the website and do a search to see what might be in there. And so the interventions that we put in there aren't necessarily things that you would find in a peer-reviewed article or anything like that, but really things that community members have shared with us that they have started working on and are developing some evidence for, but might not necessarily have the rigor that most of our other national databases require at this point. And so on the next slide, you'll see just a screenshot of a sample of projects that are in there. You can do a search. On the right side, there's a little box where you can do a search. We also have tags and tagged different kinds of things you can see that kind of tend to pop up in terms of the most popular kinds of entries that are in there. But I encourage you to take a look and see what's in here. Part of the NED's mission is that we don't reinvent the wheel. that there's a lot of great work that's been done in communities, and we want to share that with you. And so you have the opportunity to reach out to the program developer or developers or the community agency that has done the work and see if it's something you might want to try out in your community. So the website is at share.ned.net. And so I encourage you to check it out, and if you have any questions, feel free to let me know.
Next steps, we want to make sure that you have the tools that you need to pursue community-defined evidence. There are just a couple of other resources in addition to the share.ned.net site. The California Institute for Behavioral Health Solutions has an entire webinar series that you can go on to and hear. There are many different webinars there. Some are population-specific, pretty interesting. And then the California Reducing Disparities Project, I mentioned that all of these stakeholders came together to build a strategic plan, which is still awaiting release by the California Health and Human Services Agency, and so it has not yet been released, but there is a draft of the strategic plan, and there are 5 different stakeholder-generated reports for those 5 different populations that I mentioned on this website. But I have this message to download soon because the California Department of Public Health is making a transition from its old website to its new website, and these reports have not yet been posted on the new website, but they're on the archive site, and if you go to them, you can download any information that's there, and I'm not quite sure when it's coming down, but it should be fairly soon, within the next couple of months, that it's coming down, and there's just a lag in putting stuff back up. So really good resources there. We just want you to know that additional assistance is available for you, that you can get one-on-one technical assistance from Rochelle or myself or others who are in the consultant pool or the other staff that are on at CARS. So this is available to you. If it's useful to you, if there are additional resources that you need to kind of work through what your individual issues are for your site, for your community. And Rochelle, did you have any parting words?
I just wanted to encourage folks to join the NED if you haven't already done so. It's free, and you can do it on our website at ned.net. And it just allows you to see some additional opportunities and resources that might be useful in your ReCAST work.
But if you do realize that you have questions after the fact, you can always send them in, and they will be passed on to us. Joanne, what's the best place for people to send questions if they have them?
We have the general now is the time email address, NITT-TA at cars-rp.org.
Okay, fantastic. Good. All right, well then everyone enjoy the rest of their days.